Onc Live Insights is a video editorial program produced by Onc Live.
Double-refractory disease is a difficult concept to define, first, because it's a dynamic concept that it's evolving over the time, and it's different even country to country depending on the approvals. The classical definition of double-refractory referred to patients refractory to bortezomib and thalidomide and or lenalidomide, the first generation PIs and the first generation immunomodulatory drugs. And for this patient population, the challenges were to try to design it to have new agents able to overcome the refractoriness to bortezomib and lenalidomide and thalidomide. However, pomalidomide and carfilzomib emerged as second-generation PIs and IMiDs respectively. So now we can have in our clinical activity a novel double-refractory myeloma patients, probably quadruple refractory myeloma patients, because they are not going to be refractory only to bortezomib and lenalidomide, but also to pomalidomide and carfilzomib. So probably in the near future, we will have to talk about double refractory to PI and IMiD, and to specify which type of PI and IMiD are actually refractory to. And of course, the major challenge for this patient is to find the new agents, probably with a different mechanism of actions, able to overcome the refractoriness to this heavily pretreated patients population.
I think to some degree the utility of proteasome inhibitors and immunomodulatory agents has been exhausted. So there are variations on a theme, and it's very clear to me that none of those themes are curative for patients. So it's very self-evident that we need different classes of drugs. So on the horizon, there's quite a deal of excitement in that we have various monoclonal antibodies coming into development. And in fact, there's now phase 3 data suggesting that elotuzumab is going to be a tremendous addition to the therapeutic armamentarium. There's a lot of excitement about anti-CD38 antibodies, so I think they may well change the therapeutic environment. In terms of other agents, we've got epigenetic modifying agents, and now the approval of panobinostat, which I think will enable its incorporation into various combinations, because evidence would suggest that it synergizes very well with a whole range of other drugs. It's now becoming evident also that other small molecule inhibitors, which inhibit specific pathways which we know are critical in myeloma, have got demonstrable activity in trials that have been undertaken. So I'm sure that they will become more routinely evaluated in further clinical trials. So there's a whole range of options emerging, which I think will add to proteasome inhibitors and IMiDs, or in fact in some patients perhaps with poor risk disease entirely replace them, because the evidence for those agents in poor risk disease really is lacking.